whose bona fides in this area are unparalleled. And I'm going to do quick introductions of everyone in order of presentation. So we're going to start with Shelley Weissman, and apologies for looking off screen while I have their bios here in front of me. Shelley Weissman is the acting director of the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center. She works on project portfolio focused on the overdose epidemic, addiction policies, barriers to treatment for substance use disorders, public health approaches to drug policies, and how the law can promote access to treatment and support recovery. And by the way, the bios and contact information for the speakers will be sent in the post-event email. Our next speaker will be Daniel Blaney-Koen, who is a senior legislative attorney with the American Medical Association's Advocacy Resource Center. The ARC, the Advocacy Resource Center, attorney focuses on working with state and specialty medical societies on state legislative, regulatory, and policy advocacy. In addition to his work in the ARC, Daniel has held several roles at the AMA, including serving as a public information officer, policy analyst, and speechwriter. Currently, he focuses on state legislation and policies concerning the nation's drug overdose epidemic. Our third presenter, Dr. Edwin Chapman, has practiced in Washington, D.C. for over 40 years, specializing in internal medicine and addiction medicine. Over the past 20 years, he has investigated the complex mix of addiction, undertreated mental illness, infectious disease, criminal behavior, and chronic diseases in which patients have 20 to 25 years shorter life expectancies. He received his BS and his medical degree from Howard University and he completed his internship and residency in internal medicine, as well as a fellowship in cardiology from the historic Friedman's and Howard University hospitals. And then finally, our fourth presenter, Dr. Roger A. Mitchell Jr. is the chair of the Department of Pathology for the Howard University College of Medicine. He recently served as the interim deputy mayor for public safety and justice here in the district, as well as the chief medical examiner. During his tenure as the DC chief medical examiner, he gained a strong insight on the social determinants that lead to violence affecting our most vulnerable communities. And he has a great interest in violence as a public health issue and has recently co-authored position papers for the National Medical Association and other entities. Additionally, he recently served as the national co-chair for the National Medical Association's Working Group on Gun Violence and Police Use of Force. So you don't want to hear from me, you want to hear from these people. Shelley, the floor is yours, and thank you to all four of you for speaking today.
Great, thank you so much, and hello and good evening to everybody. A little bit more kind of about my perspective. I've been at Georgetown for 2 years. I also teach at the Law Center, as well as in a new program at the Graduate School of Arts and Sciences, which is going to be a master's in addiction policy and practice, first of its kind in the country. We're extremely excited. It starts in July. Wanted to make sure you all knew about that. It's an interdisciplinary program that is in collaboration with the Law Center, the Med School, Public Policy, and other schools at Georgetown. And we're super excited. And before Georgetown, I worked in state government for a number of years. I worked for the governor in New York and in state agencies doing a lot of Medicaid policy, mental health, addiction, and disabilities. And I'm a lawyer by training. I'm also a person in long-term recovery from a substance use disorder. And I share that because we're going to be talking today about a lot of what I'll call alarming statistics, overdose deaths, kind of very downstream interventions that need to be implemented in order to stem the tide. But it's important for me that I share my own experience when I'm speaking in groups like this to show that recovery is real, recovery works, and there is hope and light at the end of the tunnel, and that all the work that you all are doing every day is extremely meaningful in changing the lives of people just like me. So I'm going to talk a little bit briefly about the kind of current landscape we have nationwide of overdose deaths and trends that we're seeing I'm going to pivot a little bit to some federal trends related to kind of bills in Congress and new things that we might be seeing on the horizon, and then touch a little bit about what are some implementation, I guess, measures or initiatives that are going on in states around the country and in DC as well. So, I don't know if everybody kind of saw the recent numbers from the CDC, the latest numbers on overdose deaths from September 2019 through August 2020, over 88,000 overdose deaths. And this is, to put this in perspective, this is bigger than what it would take to fill the largest football stadium in the country. It's more people than if you took Nationals Park and filled it completely and put two of them right next to each other. It's more people than that. And it's a record high. It's almost 19,000 more deaths. That's 27% than the prior 12-month period, same years, same period in the previous year. So it's enormous. It's more than ever. We are truly in a crisis. And it's not really just the deaths. It's, other incidents that happen related to overdose. We saw an article recently, a study around overdose related cardiac arrests in 2020. And even just through August 1 of that year, there was almost a 50% above baseline increase. Substance use disorder, it's a really complex issue, right? And what we're seeing is that it is being exacerbated by COVID and the conditions in COVID, by a poisoned drug supply with synthetic fentanyl, and really the kind of isolation, economic stress, social stress. These are the conditions which addiction thrives, right? And people have trouble accessing treatment. The drug supply is tainted, and people use and die. We just, in my own recovery community, we just lost somebody last week. Brian, his name's Brian. He'd been clean for several years, had, a wife, an 18-month-old baby, and, used and overdosed. And we have, stories like that over and over again. And what we leave behind, right, is kind of this trauma to family, to the children, and it becomes an intergenerational issue. So we really have a very serious issue here. And what we're doing, which, is more probably than in a long time, is still not enough. It's still not working. And so I think, the focus that I know my colleagues are going to speak about, and then I'm going to speak about briefly, is, what can we do right now to make a dent in this issue, to address this issue? And the biggest kind of message I would have to this group is to be a part of increasing access to evidence-based treatment for substance use disorders as a key intervention. And really what we're talking about is medications like buprenorphine to treat opioid use disorder, that, the more uptake and increase that we can have in access to this evidence-based treatment that we know works, that we know significantly reduces overdose deaths, the more we can start to save lives and help people engage and find recovery. So there really are a number of things going on Capitol Hill right now and in the White House, a kind of new wave of federal efforts to address the issue of substance use disorder. For example, in the latest COVID relief package, we saw $4 billion included for SAMHSA, for HRSA, to address behavioral health, and also for the first time ever, a specific set aside for harm reduction services. HHS recently announced that federal funding can, again, for the first time ever, clearly announce that it can be used for things like fentanyl test strips, and indications have been made that there will be an effort to address some of the barriers associated with access to treatment, such as addressing barriers related to the X waiver, which is required to prescribe buprenorphine. And some of the priorities recently announced include racial equity. This is, really key because what we see is huge disparities in prescribing of medications like buprenorphine, racial disparities. And also a lot being looked at related to some flexibilities that have been offered related to COVID, like telemedicine, like certain prescribing across state lines, other access issues, and looking at those being made permanent. And there also are a host of bills. There was actually a big hearing today at the House Energy and Commerce Committee in Congress. And a whole host of bills have been introduced. One is the MAT Act, which would eliminate the X waiver requirement to prescribe buprenorphine. The MATE Act, which requires certain training of prescribers of controlled substances. There's another bill called CARA 3.0 is what we're calling. It's kind of the third iteration of a big bipartisan package that does many things, but some highlights are that it mandates physician education. It authorizes $300 million to expand access to medication-assisted treatment and $200 million to build a national infrastructure for recovery support services, which would be awesome. Another highlight, the Medicaid Reentry Act, which provides Medicaid to people who are incarcerated 30 days pre-release. Right now, no, you can't get Medicaid if you are incarcerated. So this would help connect people to treatment before they leave an incarcerated setting. So we're seeing a lot of activity and a lot of discussion amongst elected officials that this issue is being taken very seriously, and hopefully some progress will be made very soon. A couple things I wanted to highlight on state level action. So, in the world of public policy, right, we can pass laws and make policy, but the devil's in the details with implementation. And states or DC have to kind of take additional action in order to implement and really take full advantage of these changes. So some of the things we're seeing again across the country are, and including in DC, is an effort to connect people with treatment when they come to the hospital following an overdose or following a screening for substance use disorder, connecting people to buprenorphine, to next day or even same day appointments or bridging services. And we're seeing some great models. I know this is happening in a number of hospitals in DC. We're seeing wonderful models happening in California, New York, and also really taking on barriers related to insurance access, both in commercial insurance and in Medicaid. So actions like limiting or prohibiting prior authorization for outpatient services, for medications, and much more transparency related to medical necessity criteria, and ensuring that physical health services and behavioral health services are provided at parity. Now, it's all over the place, I would say, across the 50 states and the district about how well these requirements are being implemented or if they're being implemented, but that's where we're seeing the most uptick in access to services, as well as efforts to increase the quality of treatment. So, main takeaway, I think, that I wanted to leave you with in my brief time is there's a lot of progress to be made. There's a lot of good, strong work going on, and a lot of it is being led, I know, by my fellow panelists and other folks that are tuning in, and more work to do, but there's hope on the horizon, I believe. So with that, I'll turn it back over to Robert. Thanks.
Thank you, Shelley. Great perspective. I just want to recognize that Dr. E.W. Emanuel has joined our meeting today. And Dr. Emanuel, if you want to say a word or two before we go on to Daniel, just hello to people. I think we have to unmute you first. You have to unmute yourself.
Well, thank you, Robert, for that. Thank you, everyone, for coming. I appreciate your presence and our speaker. And please excuse my tardiness. Ran over seeing patients.
All right, Daniel, you're up. Thank you for joining us.
Thank you, Robert, and thank you, Dr. Emanuel, for the opportunity to talk to physicians in DC. As Robert introduced, my name is Daniel Blaney-Koen. I'm one of the attorneys in the AMA's state legislative unit, and I want to build on what Shelley was talking about in a couple of ways, and not only provide that state and national perspective, but get into issues about implementation in the states and provide hopefully provide some tangible examples that may not be unfamiliar to the physicians here, but to sort of demonstrate there is a lot of action that can take place. And I'm going to try to get into some specific recommendations. And for all of this, I'm sure I'm going to leave something out. So Robert always knows how to get to me. And every physician on the call today, please feel free to reach out to me at any point. I've worked at the AMA for about 20 years. It has been a privilege to work for physicians for that entire time. I'm at your service. And those physicians who do know me know that you can reach me at any point in time. So Shelley mentioned the national perspective a little bit, and as physicians know, and you'll hear more from them, the epidemic has changed dramatically, and from one that was driven initially in the early 2010s or so from prescription opioids to related mortality to one that now is a polysubstance, mainly illicit fentanyl analogs, methamphetamine, cocaine. Heroin continues to be a problem, and overdose and mortality and morbidity related to prescription opioids remains an enormous problem. So Shelley emphasized that we're not out of the woods yet. And my inbox is a really terrible place to be, because on a daily basis, it's horrible story after horrible story. My 3-year-old, in fact, is telling her brothers about some other horrible story in the background. So I apologize for that. But at the core, the two most important metrics to the AMA has always been, we want people to stop dying, and we want to improve patient outcomes. So if a policy doesn't meet those two basic thresholds, we're not going to support it. And there's a lot of nuance in between, but those are the two threshold areas that we are going to handle. So I want to get into some of the issues. Shelley mentioned some of the current federal flexibilities, and as everybody knows, two of those during the public health emergency for the COVID-19 pandemic were to relax rules for the initiation of buprenorphine that can be now initiated. Patients can be inducted via a telehealth visit, and that's great. And there are additional rules relaxing take-home medication for opioid treatment programs per physician discretion. But here's the kicker. States have to change, and the district needs to address payment policies to support physicians doing those things. So that's sort of recommendation one. And if I lose count on how many recommendations I give, it's only because I'm a lawyer and math is not my strong suit. Second, closing the treatment gap. We all know and this has been for years, 10 to 20%, only 10 to 20% of patients with a substance use disorder get the treatment that they need, despite paying premiums for the insurance coverage that they have. So the recommendation here, we have been working with and calling on health plans in every state and calling on departments of insurance in every state to go ahead and ask the health plans in an official capacity how many physicians prescribe buprenorphine for opioid use disorder in the network. And insurance plans in states have told us, we don't know. And we have responded in kind, and departments of insurance in other states have responded in kind, saying that is not acceptable. So the Department of Insurance needs to hold health plans accountable and ask them, who is providing evidence-based care for a substance use disorder? If the insurance plan doesn't know, we need to work on that. And that is the second tangible recommendation that I would want you to leave with. Third, enforcing mental health and substance use disorder parity. This is, as Shelley noted, this is a really fertile area of state policy engagement. The Department of Labor has new rules that are great rules. It gives lots of new power to regulators, but they have to use them. And then one place that they can start using them is simple. We call it enhanced attestation. It's also called prospective attestation. And what it basically means is that a health plan is required under current law to do the analysis that their plans that they offer are in parity with the substance use disorder benefits and mental health benefits, that they're in parity with the medical and surgical benefits. Well, the only way that they can know that they are on par is if they do the analysis. And what we want departments of insurance to require is that health plans provide departments of insurance with that analysis before the health plan is able to offer that plan to patients. If they can't demonstrate that they're in parity, guess what? They're probably not. So this is current law. We want them to demonstrate ahead of time that this happens. So that's recommendation 3. Recommendation 4, patients with pain. Pain has long been an unrecognized and undertreated medical condition in the community. It's abhorrent, the inequities in treatment for Black and Brown Americans compared to white Americans. So the equity lens has to be played on pain. We also have to directly address the fact that health plans and pharmacy benefit managers continue to promote $4 generic opioid prescriptions while putting non-opioid pharmaceuticals and other non-opioid modalities on formulary tiers and benefit design packages that are cost prohibitive for patients. This is another area where we can work with employers. If employers want their workers to have better pain care, it's incumbent upon employers to go ahead and take a look at their own benefit packages to make sure that they are also promoting non-opioid pain care. So recommendation 4, this is a great area for the medical society, for the employer community, for the DC chamber and others to work together on saying, it's the pain situation is out of whack. We can't promote opioid analgesics on one hand with these low costs, target doctors for treating chronic pain on the other hand, and then not provide any other options. So we have to restore some balance, and the medical society can be a great leader in this regard. Next, harm reduction. Shelley mentioned new harm reduction packages and tens of millions of dollars for states to purchase. Now states can have the authority to purchase fentanyl test strips, for example. It's a hugely important harm reduction measure. It's not necessarily going to end the epidemic, but it will save lives. However, states are going to have to ask, and you're the experts in the district, states are going to have to make sure that their drug paraphernalia laws don't include testing supplies as drug paraphernalia. We can't start asking harm reduction organizations to supply fentanyl testing strips and then have law enforcement arrest people who are trying to make sure that it's an unadulterated supply of fentanyl. People who use drugs need to be met where they are, and fentanyl test strips are one place to meet them where they are. So reforming Good Samaritan recommendations, next part, and I lost the number where I'm at. Finally, I mentioned equity briefly, but we need to make sure that equity is embedded in each of these recommendations. And one place to do that is to work with health plans, work with the relevant DC agencies to ensure that the data is being collected. And that the data is disaggregated by race, by gender, by age, by zip code. And then to work with the department, the relevant agency, and I don't know what the relevant agencies all are called in the district, but to take a look at where is care currently being provided? And if that care is currently being provided, and to look at that, again, by race, by age, by gender, by ethnicity, by payment status, by income level. And then only when we have that data are we going to be able to target interventions appropriately and equitably for patients. So again, I covered a lot. I don't think any of it was poetry, but it is actionable information. So I'd be happy to answer any questions. I really appreciate you letting me run through a few of those things.
Great. Thank you, Daniel, as always, for a great perspective. We have a couple of questions in the chat, but I'd say let's save those for the end and turn it over to Dr. Chapman, who is queued up with his slides.
Well, thank you, Robert, and thanks for inviting me. This is certainly an opportunity to address this very serious topic. This first slide actually shows the evolution of the epidemic over the past year. And the dark brown areas show states or jurisdictions where there's been a 50% increase in overdose deaths in the past year. And you can see the district is standing out as somewhat as an island surrounded by Virginia and Maryland. So we know that fentanyl is the culprit. But when we look at the District of Columbia, not only do we stand out, we're number one in per capita overdoses at 60. So we jumped from 39 per 100,000 to 60 in the past year, which is astounding, which tells us that there's a bigger problem here. And we're going to try to elucidate some of that. This is a graph out of the new Live Long DC 2.0. And you can see in 2020, we had 408 deaths compared to the two highest previous years, 2017 and 2019 with 281. We went from 20% fentanyl in 2015 to 94% fentanyl in 2020. So that should tell you something. Our patients are not overdosing predominantly on pills from the doctor's office. They're overdosing from street drugs. So that also gives you a heads up on strategies. My look at this really makes me feel that even though we have the farm benefits management now in place, that's going to have very little impact on our overdoses. And we can see from the latest chief medical examiner's report that, again, as usual, about 80% of the overdose deaths are African Americans. But we can also see, if we look at this particular diagram, that there's been an across the board increase in overdose deaths in practically every age group. And particularly in the 40 to 49, 50 to 59, and 60 to 69 age groups, and even a doubling in the 70 to 79 age groups. We also know that most of the overdoses occur on the east side of the city. And the red arrow shows where my office happens to have been for the past 40 years. So this was not by design. When we look at the District of Columbia, wards 1, 2, 3, and 4, of course, are predominantly white, disproportionately Black on the east side. And you can see the marked increase in overdose deaths in Ward 7 and 8. I put this slide of homelessness in because we can't address this unless we talk about structural competency. So you can't just sweep the homeless off the street and for aesthetic purposes, because we know that there's a very high incidence of mental health problems and substance abuse problems. So when you do that, that really lays to bear the question of structural competency. So I'm going to talk a lot about structural competency, because there's very little that we can do as physicians if our patients are unhoused. It becomes a revolving door with stress, et cetera, leading to more drug use. So here we can actually see the increase from 2015 to 2020, that there's been a 200% increase in deaths among the homeless. And again, with the PDMP, we can see that only 9 patients in 2020 even had buprenorphine in their system. And I think, at least in talking to Dr. Mitchell, who will speak to this later on, that as far as I know, they've never found a patient with only buprenorphine in their system that overdose. So it's always a combination of drugs. And we can see that methadone is about 3 times as high, but again, the methadone in many instances is diverted on the streets and may be among patients who were not actually prescribed it, but got it from a friend trying to relieve their withdrawal symptoms. So we know about our history of mass incarceration. So our problem is a little different from the problem in the rural and suburban areas, in that we have to undo or reverse the past 50 years of incarceration. My patients average 52 years in age and 10 years of incarceration. So these arrest records dealing with the court system, dealing with homelessness, dealing with unemployment becomes a composite problem in addition to just having a substance abuse problem. This is the age range of my patients, and you can see most are between 50 and 69. And this was taken pre-COVID. This was actually taken in December. I actually have 2 patients who are 80 and a third patient who is 80 but dropped out of treatment and is out in the community. So when we look at the District of Columbia, there are 250,000 patients on Medicaid. 22% of that population spends 53% of the Medicaid dollars, averaging about $25,000 a year. So this is the patient population that we're talking about. This is the complex, high-risk patient population that rotates in and out of the hospital, a revolving door, because they're never appropriately treated. And appropriate treatment requires a lot of services outside of the doctor's office. Shelley has mentioned buprenorphine, which is probably the preferred medication of the 3 medications that we use. Everybody's familiar with methadone. The third medication is Vivitrol, or injectable naltrexone. But we can see in this study that was published last year that only 2.7% of buprenorphine prescriptions nationwide are prescribed to African-American patients. And that's not by accident. There's a long history behind this. I was there with the original rollout of buprenorphine, and it was really not marketed to urban heroin addicted patients. It was really thought to be best utilized in the suburban population. And the fear was that it's a Schedule III drug, and the companies were concerned that it would be, that if it was diverted on the streets, it would be become a Schedule II drug like methadone, with a lot of restrictions and therefore not prescribed out of the doctor's office. So this is an article out of the Federal Register, November 2nd, where the federal government was actually trying to expand buprenorphine treatment to more nurse practitioners, PAs, et cetera. And the rationale behind that was the fact that it costs about $7,500 a year just to treat the substance abuse itself. Untreated, these patients cost the system, by the federal government standards, of $42,000 a year. So you can see that because of the complexity, the fact that these patients are high risk for AIDS, 10 to 12% of my patients have AIDS, about 50 to 60% hepatitis C when they came into the practice, so that to treat that costs, especially the hepatitis C, upwards of $100,000. So we got a lot of pushback from the insurance companies in terms of just getting patients treated. Now, when we look at mental health and substance abuse, to each one of these bar graphs and each one of the diseases so described, to the left the blue line actually shows patients who do not have a mental health or substance abuse problem. If you look at the reddish orange line to the right in each one of these chronic diseases, you can see that the cost of any chronic disease quadruples if you have both a mental health problem and substance abuse problem. And that makes sense. If the head's not working, a patient's not going to seek medical care. And if they seek medical care, they're probably not going to follow their medical regimen. So this is, again, a diagram of my patient population in December of 2019, and about 80% were opioid free. Those who were completely non-compliant, about 14% using either cocaine or testing positive for alcohol or some other drug. And then partial compliance was 7%, and non-compliant was 14%, actually still testing positive for opioids. But because they test positive for opioids does not mean that they're not better in a harm reduction model. And then when we look at just theoretically, if a patient has a $50 a day drug habit, and you multiply that times 365 days a year, generally they have to do something upwards of $100 to $150 a day illegally in order to get the money to buy the $50. So by treatment, just looking at this population, we save $8 million in petty crime, shoplifting, drug sales, prostitution, et cetera. So when we look at this in its composite, there are three areas of savings. One is the medical savings. So we can see the 42,000 cost in medical costs, but there are also criminal justice costs that come to about $35,000, whether you're incarcerated or not incarcerated, those costs go on. And then there are the social service costs, lost employment, children placed in child and family court. All of that is being paid for in taxpayer money. So when we really look at the savings from treatment, an untreated patient costs the system compositely about $112,000 in this scenario. If they are significantly reducing their drug use, we can lower that cost to about $52,000. And if they're completely drug-free, we can actually save about $62,000. So when we look at what we're doing compared to the Ryan White carve-out, and Ryan White, they developed a knowledgeable specialty network. Then the government put money into that, and combining the two actually saved money. So there was a tight fit. And what we really are looking to do with substance abuse is to create that same model. So I was on a panel with the National Academy of Sciences headed by Dr. Carlos Del Rio in 2019. And we looked at all of the barriers to care. And I'm not going to go through all of the details but they're listed here. And number one on the list is prior authorizations. Shelley talked about that. And there's a reason for that, because any type of barrier to treatment causes patients not to, and physicians to get frustrated. So we now know from some very good studies that it actually increases ED visits and hospitalization. So the short-term savings that insurance companies seek using prior authorizations actually cost the system more. This is a map showing the dark blue states are states that have gotten rid of prior authorizations. The district is actually listed as having gotten rid of prior authorizations, but that's kind of a hybrid model. We still have to get prior authorizations for dosing buprenorphine above 24 milligrams. And I won't go into the details, but most of our patient population started with street drugs, if they survived to fentanyl, and we already know that 94% are on fentanyl, it tells you that they are most likely ultra rapid metabolizers of these drugs to even live and walk into the office. So what we found from a study we did through Howard School of Pharmacy and my office is that our patients do better on higher doses above, generally above 24 to 32 milligrams. This is the slide actually showing the reduction in hospitalizations and emergency room visits with getting rid of prior authorizations. Another nuance item out of the study from the National Academy of Sciences is the fact that there's not enough money in the harm reduction services or payment for harm reduction, needle exchange, telemedicine, peer recovery counselors. Those are generally not paid for by health insurance. And then same day billing restrictions. In other words, if a patient comes to my office and we wanted to zoom in a psychiatric visit that both would not be paid for, that is a barrier to care. So this is a model of how my office is set up in theory with a social worker. All of this is through telemedicine, a peer coach that I have now through a grant from SAMHSA and one of the local faith community organizations, remote remote or in-office primary care services, and remote or in-office psychiatric services. And of course, everyone knows that in the African-American community that only about 4% of psychologists are African-American, 2% of psychiatrists. So that is a major barrier to treatment. And these are structural barriers. So this is schematically how 7 years ago, I redesigned my office with telemedicine, electronic medical records. And the idea was, knowing that I'm not a psychiatrist, but I do primary care and substance abuse, that if I could use telemedicine and partner with someone who was a psychiatrist or with one of the community hospitals, that patients could come in and have one-stop shop. They could receive social services, psychiatric services, substance abuse services, because this is a population that you can't give paper referrals to and expect them to come back having followed through, because they have issues like transportation, child care, and just the fact that they're not going to go. So this is a study that's actually being done in New Jersey. And this was reported by the Foundation for Opioid Response Efforts. It's being overseen by Rutgers University, again, with the elimination of prior authorizations and inserting peer support in the practice to see if this actually works. And finally, we know that 80 to 90% of health outcomes are related to things outside of the doctor's office, structural things like housing, community support, and all of the issues that Daniel and Shelley have already mentioned. So I'm going to stop there and thank you.
Thank you very much, Dr. Chapman. As always, very informative. We're going to turn it over now to Dr. Mitchell for his thoughts. Thank you, Dr. Mitchell, for being here.
Oh, my pleasure. I don't know if you can see me or hear me. Thank you so much. Thank you for having me on as part of this panel, and just being able to listen to my colleagues talk about this issue. I think is extremely important. What I find is most interesting about, well, let me just tell you my background. As stated, I used to be the chief medical examiner, immediate past chief medical examiner for the nation's capital, and interim deputy mayor. And now I'm at Howard. one of the big things back in 2014 when I first arrived in the district. There were not many opioid-related deaths. There were maybe about 5 or 6 opioid-related deaths a month. So I just need you to put that in perspective. About 5 or 6 opioid-related deaths every single month back in the spring of 2014. In the summer of 2014, I saw it rise to about 9 in a particular month. 9 opioid-related deaths in a single month was the highest number of opioid-related deaths that the district had seen. Now, before I got here, they were not measuring any of the opioid-related deaths. All of the charts and graphs and epidemiology, forensic epidemiology that you saw that Dr. Chapman presented out of the Office of the Chief Medical Examiner did not exist as a consumable tool for public health officials and clinicians like yourselves to be able to identify how to treat patients dying of preventable injury or disease. The medical examiner has access to real-time deaths, but not all deaths. The medical examiner only deals with non-natural deaths in total, and deals with some natural deaths if they're sudden, unexpected, and die unattended in someone's home. But all homicides, suicides, accidents have to be reported to the medical examiner. So that gives you a little bit of context. The majority of these cases are accidental cases. So in 2014, the high number was 9 when I first got here. So I put in a surveillance program. The surveillance program was intended to track that. I knew where I was coming from, which was New Jersey. I was seeing opioid-related deaths increase among the suburban population when I was chief medical examiner in New Jersey. Fentanyl had not hit the scene the way it hit at that point. Fentanyl was not something that we were seeing on a regular basis. If we did see fentanyl, it was people obscuring prescription fentanyl and or using fentanyl patches and heating them down and then consuming them or chewing the fentanyl patches. So large of my career, I've seen people die from fentanyl overdoses, but these were fentanyl that were prescribed and diverted fentanyl. It was not until the last 5 years that synthetic fentanyl had been created and being brought across the border from China and Central America through Mexico that we have seen this increase in deaths. As you heard, the majority of these individuals are well-established users, then now you add fentanyl. He showed over 80% of all opioid-related deaths are associated with fentanyl in the District of Columbia. So to Daniel's point, understanding who they are, where they live, to the block, street, heat, GPS analysis exists in the District of Columbia. The problem of who they are and where they get their care, where they go to the supermarket. I live around the corner from Dr. Chapman in Ward 7. I know exactly where those individuals are that are suffering from substance use and abuse. The question is, how many physicians are actually seeing these patients in their practices, right? How many physicians are willing to diversify their practice enough to be able to see these patients and be able to make sure that you're providing buprenorphine so that Dr. Chapman and a couple other individuals in the District of Columbia aren't the only physicians seeing these patients. If it feels like I'm in your pockets and I'm talking to you and making you feel uncomfortable, then I am, because people are dying and people are dying from a preventable disease that requires medication in order for you to get well. This is not a disease where you can brush it off, suck it up, stop using and not use. Similar to Shelley, if I heard correctly, I come from a personal experience. My dad was crack cocaine addicted my whole childhood. So understanding what substance use and abuse does to a family, what it does to an individual, hits home for me. Now he's been sober for years and was a substance abuse coordinator at the Veterans Hospital and actually contracted with Dr. Chapman and worked as a peer navigator with him, right? But he did that largely because he got the help that he needed. And another reason is because he, you know, it was cocaine. So he could operate himself out of the cocaine addiction. I'm not going to talk long. We're getting down close to the hour, but what I wanted to point out is that as long as we have, and again, the government has a huge role, right? And so there needs to be advocates for proper healthcare delivery, for removal of barriers to making sure that these patients get care. I was the deputy mayor for public safety and justice, and I know that government responds to pressure. But let me tell you, Dr. Chapman is a loud voice. He's a loud voice, right? But he's a singular voice. And so we need more physicians with white coats. We need more practitioners and researchers and academicians to come together and put a considerable amount of pressure on the local government to do what you're asking them to do. And what does that mean? Not just from a philosophical standpoint, but the fact that we're seeing the patients. No one will question whether or not Dr. Chapman sees the patients that suffer from substance use and abuse. When I was practicing as the chief medical examiner, I absolutely saw the patients from substance use and abuse. And this year is the most ever. Did you see that? 369 deaths in 2020. The whole government has mobilized to COVID. Right, and granted, I moved over 1,200 bodies through my morgue for COVID, which I ran the disaster morgue ops. So it was considerably a enormous amount. But the homicides are up as well as the opioid abuse and substance abuse. So there's work that needs to be done. You know, I'm happy that the organization is putting forward these types of conversations. And so we encourage in physicians to get involved and diversify your patient population and see these patients so that you can see the barriers that Dr. Chapman sees, but also you can put yourself in position to advocate for the necessary changes so that we can get our patients more access. So I'll stop there. Thank you so much for having me, and I appreciate being part of this discussion.
Thank you, Dr. Mitchell, and all our speakers. This is Dr. Emmanuel. It is 6:24, and I know some people have, Dr. Mitchell, yourself have a very hard stop, but do we have room for one question? And then we'll take questions via email and get the answers back to the remaining audience. So is there a question out there?
So Dr. Emanuel, we have a couple of questions in the chat.
Okay, Robert, thank you. Can you, can we present one or two for our hard stop?
Sure, a couple of platitudes for the speakers is a big one. And then a question that came in, I believe this is in reference to Dr. Chapman's presentation, but open it up. Do you have any research citations to share addressing the effectiveness of FTS during this period when fentanyl and analogs are the predominant opioids being used? I apologize if I misstated that question.
Could you state it again? You said
the effectiveness of FTS during this period when fentanyl is the predominant, fentanyl is the predominant opioid being used. It would seem the benefits of was originally demonstrated when heroin was adulterated with fentanyl. Not sure how this applies to advocacy, but this just came to mind.
Okay, I'm not sure what FTS is.
I think it's fentanyl test strips.
Oh, the fentanyl test strips. The fentanyl test strips were originally considered to be contraband. And people, as I think Shelley mentioned, that people were being arrested for possession as if they had drug paraphernalia. But now I think, and this is all part of harm reduction and understanding what harm reduction is all about. We went through this whole cycle with needle exchange where the district, because of congressional mandates, could not use their money for needle exchange. And I understand from friends in West Virginia that now there's a push in West Virginia to ban needle exchange, and they're having an AIDS and probably a hepatitis C epidemic. So it's really incumbent upon us to, as medical practitioners, to educate the community in terms of what harm reduction means and what it does and what it does not do. So we spend a lot of time talking to church groups, talking to senior pastors, talking to community groups to really inform the community as to what the real scientific outcomes are. And when needle exchange first came out years ago in Baltimore, Johns Hopkins actually took the needles and the syringes and tested them for DNA samples, and they could tell whether they had been used by 1, 2, or 3 people. So there's science behind this whole phenomenon, and I think having the fentanyl strips is not going to encourage people to use. It's going to give them another tool to be safe. Again, there in Vancouver and many European countries, they have safe injection sites. Again, we're going to have to go through the same process, but according to the literature, nobody has overdosed and died in a safe injection site because they have medical personnel on board. So the question is whether we want to be judgmental and let people die, or whether we want to give people a second chance and then an opportunity to connect them to treatment.
And Dr. Chapman, if I could, to build on that, one of the things that we see in state legislature after state legislature after state legislature is that when physicians speak from their scientific and medical background, legislators listen. Just so, for example, as an addiction medicine physician, the AMA has told Dr. Chapman's story, and to great effect. As an any emergency medicine physician, on this call, I would encourage to tell your story, share the specific scientific reasons why what happens when you see a patient in your emergency department who has an infection, a blood infection due to using an unsterile needle. The infectious disease specialist, what does it mean when somebody has that infectious disease? What are the costs associated with that? The obstetrician gynecologists on this call, what does it mean when you tell a patient that you understand that she uses drugs, but you want to make sure that her and her baby are going to be healthy throughout the prenatal, labor, delivery, and postpartum period? So these are all things as physicians. I think you can look to Robert, you can look to the AMA. We want to tell your stories about the humanity and compassion, because that will move legislatures.
Thank you, everyone. It is 6:32, and trying to respect your schedule and demands. If there are additional questions, please submit them to us at MSDC, and we will get them answered to you. I'd like to thank all of our speakers addressing this very troubling topic, but needed by the community, and especially the medical community, to address it and be advocates. So again, thank you. And we will be providing you with any answers or answers to questions that have been presented. Thanks again, and enjoy your evening.